Okay. Can you see me?
Hey, are you on now?
I am.
Perfect.
Given I okay.
You good?
Huh? Yes, I think finally. That was exciting. Very exciting.
Hey, I appreciate the patience there. Jeez, Facebook it is. All right, go ahead. I'll let you to it. Thanks, Hutcherson.
Yeah, all right. Take care. Bye-bye. All right. Well, after 18 minutes of fuddling with the system here, thanks for joining us for this Facebook Live. It might be a little truncated on time now because I'm actually in the middle of clinic doing this on my like sort of lunchtime. So we'll just kind of bang through a few questions here. Thanks for submitting so many. A lot of great questions in there for sure, which I now have to pull up. Hold on. Okay. So my name is Andrew Sun. I'm a urologist specializing in male infertility and sexual medicine. My practice is in Dallas. It's in Arlington, which is in between Dallas and Fort Worth. We basically do 100% male infertility, sexual dysfunction, Peyronie's disease, different things like that, and it all goes together. So. This will just be kind of directed at a lot of these nice infertility questions, and I'll just lead off by kind of saying that this is simultaneously one of the most gratifying but also difficult parts of our job because um, the degree of scientific knowledge in the infertility and specifically male infertility space when compared to things like cancer, tumor oncology, certain things like that, it's definitely low relative to other fields. The data is just not quite there for a lot of things. So if a lot of the answers come off a little bit like wishy-washy, it's because the data is not strong enough for a lot of these things to be able to firmly indicate a yes or a no, or this is the answer, conclusively or not. So we'll kind of go through a few things. I would say we'll start off with questions. So first question was, what's the best thing to improve morphology? I will lump this into a variety of different questions, which are usually the same thing, which is on a semen analysis, you're always going to see multiple things, right? Volume, concentration, motility, morphology, and then even more, progressive versus non-progressive and strict morphology versus whatnot, lots of different things. But in isolation, each one of these things is mildly predictive, but you really want to look at it like as a whole, right? Just because you have one isolated defect in, say, your morphology, but everything else looks good, doesn't necessarily mean that you're unable to achieve pregnancy, and it also doesn't necessarily mean that we have a specific thing that's like, oh, you have low morphology, so let's do this, versus you have low motility, so let's do this. A lot of the guidance is mostly on just sort of improving the overall quality or quantity of the sperm to increase the probability that one of those sperm is going to make its way to the egg and basically be successful that way. So you almost kind of want to concentrate less on like individual pieces. Of course, they're important, and we'll talk about details there, but it's mostly like the holistic whole of the whole thing. Remember, like you could have the worst semen analysis in the world, right? One sperm, well, zero sperm, but like one sperm, 0% morphology, 1% motility, whatever, and you could still theoretically attain pregnancy. It's just that your per month natural conception probability chances are lower than someone that has like 100 million sperm of the same fertility world. Basically think that if you had one single test on a guy to give an overall idea of how healthy or not healthy he is, a semen analysis and a testosterone level is probably a pretty good option to take there, because it does give you a general insight onto health for most people. Now, we're not talking about people who have true chromosomal abnormalities like Klinefelters or Y chromosome microdeletions and those kinds of things, but for most people, the overall feeling of your sperm is a general health indicator. Usually, things will all be a little bit off, right? Like the motility is a little bit low, the morphology is a little bit low, things like that. And you can do lifestyle management alone. Certainly, if you're, I can summarize all that to say one thing, which is if it sounds like it's unhealthy, then you probably shouldn't do it when you're trying to have kids, right? So drinking, smoking, like none of these things, you can pick the data out on each one, but in general, just don't do those things as much. And then, you want to try and give the sperm the best environment to grow up in, which would be antioxidants. So certain supplements can help with that, CoQ10, vitamin C, antioxidant type things. And then you may try to hyperstimulate the body's endogenous production of more sperm. Now, even if that doesn't actually address the motility or the morphology, right, because all of the sperm parameters are expressed as a percent, yes, we think, oh, my morphology is 2%. How do I make it 5%? You could make it 2% into 5%. You could also double the overall quantity of sperm that you have. And even if the morphology is still 2%, 2% of double the amount of sperm is the same thing as 4% of the same amount of sperm, right? So sometimes your best bet is to just kind of hit everything with what you got and just try to increase the overall number. And there are medications that we can do for that, like Clomid, like anastrozole, things like that. Semen volume is another question. Semen volume is a challenging one to try and fix. Some men just have low semen volume because of ductal obstruction. That one is usually like 0, and you can sometimes see that when they're ejaculating based on the pH of the sperm and whatnot. But if they just have low semen volume, there's not anything that's been proven to improve that. You do want to make sure that, is it truly low semen volume that's being produced, or is it that they have retrograde ejaculation? Because you can have retrograde ejaculation either from diabetes or from certain medications, which means your volume is actually not low, it's just going backwards, and so what you see is a low volume. There was one Danish population study that showed that fish oil supplements improve semen volume. Take that for what it is, but why not, right? So hydration, fish oil, make sure you don't have retrograde ejaculation, and that kind of thing. If you look at the guidelines on fertility, each individual element, like I keep saying, is not necessarily individually predictive of a certain chance, but when you add everything together, each one comes together to a whole, and generally, you could give a probabilistic element of yes or no. I think anybody with any sperm, you would argue that you're still able to achieve natural pregnancy, but your just probability question is going to be a lot lower on a per month percentage. When I talk to my patients, I just tell them, like, look, having a kid or achieving a pregnancy is like going to the casino and rolling dice, right? And you have to roll 3 6s. And maybe a guy with a normal sperm has 10 dice, and so you might take 3 rolls to roll it. You might take 5 rolls to roll it. You might roll it during the first time. You, Mr. X, who has motility, morphology, whatever deficit, you can still roll those 3 dice, but maybe you only have 3 dice, right? And so it just might take longer. You remember that the semen parameters, how do they determine these numbers of the semen parameters? All of the men, it's like 5,000 semen analyses, and they just take the 5th percentile of men who are still able to achieve pregnancy, and those are the semen parameters, right? So everybody whose semen analysis is used to create the semen parameters has achieved pregnancy, and you just take what is the 5th percentile of all of those guys, and that's what we call low. So it's not that anything magical happens below that low cutoff. And even if you're right above the cutoff, are you at the 6th percentile, the 7th percentile, right? It's all just a continuum of a probability estimate, and you're just trying to improve your probability as much as possible by working on the overall number and working on the individual things. But because there's not a specific thing for each one of these targets necessarily, then you just do healthy living, lifestyle, counseling, weight loss, fertility vitamins, and sometimes prescription medications, Clomid, anastrozole, letrozole, these kinds of things. Next question was, what results have you seen from varicocele removal as far as improvement in sperm counts? It varies. Varicocele is the most commonly found treatable cause of male infertility, but a lot of people have varicoceles and they don't have male infertility. Generally speaking, varicocele is affecting the left side more than the right, and so maybe those guys have a varicocele on the left, but they actually still have good sperm production on the right side, and they don't see any kind of defect in their sperm production. I definitely have seen favorable results, especially when you have a good significant varicocele, especially if you start to see like maybe some size differences in the testicles. These are usually the left varicocele being big and the left testicle being a little bit smaller. So I think that is still something that is beneficial and one of our go-tos if you diagnose a clinical varicocele, which means you got to be able to actually like sort of see it and appreciate it. Lots of questions on non-obstructive azoospermia, and this is definitely the most challenging version of sperm that we see, because essentially most people's semen analyses fall into one of 3 buckets. Either everything looks good and you tell them, all right, you're good. Something or multiple things are kind of bad, but not like awful, right? So suboptimal motility, suboptimal morphology, suboptimal concentration, and those guys are the ones that we treat with the sort of litany of things, right? The lifestyle, the prescription medications, and whatnot. And then you got the guys with zero sperm. Now, 20 something percent of guys with zero sperm on one Siemens analysis, if you check it again, like they may have something. So you definitely want to sort of repeat it and see. But if the guys truly have zero sperm, there's only two possibilities. Well, three. Either they don't make any sperm at all, and no force on heaven or earth will be able to make them make that many, and they're really hard to find. And really, all of our efforts are trying to figure out who is the guy that makes no sperm and will never make sperm, and who is the guy that makes just a few, and maybe you can find them in there, right? And that's really kind of the key. There are some markers that can do for that, right? A higher FSH, meaning over 7.6, generally predicts a less likelihood for making sperm or more testicular problem, non-obstructive problem. And I think some data, again, most of the data in the fertility space is mediocre at best, but some of the data would indicate that the higher the FSH level is, the lower the probability of finding sperm are, because it logically makes sense, right? The brain is like screaming, yelling at the testicles to do something, and they're not. That being said, it's not a perfect correlation, but in general, when I see labs and I see an FSH that's like really high, I'm like less happy about that than when I see an FSH that's like a little bit high, right? That's just a general statement. Whether or not you can directly use those levels to predict TESI or micro-TESI success, again, weak data for that, but some would argue that if it's like 30, 40, 50, you're maybe not going to have as good luck with a micro-TESI or finding something as somebody who has an FSH of like 8, right? Can you rank the various lifestyle factors and how they relate to sperm quality? No, you can't rank them, and so you might as well do them all together. I would probably say that weight loss is the biggest thing. I mean, if you want, I think there are some questions that, and I'll just make the general statement, which is, why have sperm counts fallen overall for the whole country? It's probably because our health is not good, right? We're just not healthy. We don't eat well. We're a little chunky. We have terrible lifestyle habits. All of these things are causing a decline in testosterone and in sperm parameters. Now, that doesn't mean that the human race is going to go extinct, because you could argue, is a decline from 80 million to 60 million a decline? Yes. Is it a statistically significant decline? Yes. Is it relevant? Maybe not, right? You still got 60 million sperm, but that's probably one sort of explanation there. But I think that basically, from the lifestyle aspect, heat is really bad, so you definitely don't want to do any hot tubs and saunas. Red light sunning your scrotum, right? It's a thing. I wouldn't do that. But the opposite of that, this is actually another question, is there evidence showing that icing or cooling the testicles helps the sperm? And I think the answer is actually maybe a little bit. You would, if you're like thin and healthy and not obese and not sitting with your balls basically sitting between your like thighs 20 hours a day, you probably don't need to ice your testicles. If you are, then icing the testicles probably does help, and that's probably why we see a signal benefit of doing that. I think the general theme is true, which is avoid being too hot, but you also don't have to like freeze them off, because all you do there is make your testicles suck back into the body, because they're actually trying to get a little bit warmer, right? So, like with most things, it's everything in moderation. But I will recommend scrotal cooling to guys that are, like, for example, classically would be like a very obese truck driver, right? So he's got big thighs, and he's basically steaming his testicles in between his thighs for many, many, many hours a day. That cannot be good for his sperm production. So obviously the first thing would be to lose weight, but then, of course, if he wants to do a little bit of scrotal cooling action, that may help as well. Okay, that's that one. So on the question of, so what are your thoughts about stem cell treatments, lab-assisted sperm growth, and that kind of thing? I think the correct doctor answer as of today is, it's really interesting, it's really exciting. We all hope that someday we can use our fancy technology and do something. I mean, you look at what CRISPR can do, and if you've seen that they like sort of edited the genes of like these dire wolves, in a Jurassic Park style, like who knows what we'll be able to do someday. As of today, we can't do any of that stuff really yet. So I'm hopeful. I think that fertility is always going to be an interesting area of research, and hopefully in the future we can sort of engineer some things to get some sperm back for especially the non-obstructive azo guys. But time will tell, and unfortunately, like not yet. What are the most effective ways to boost sperm concentration and motility, in your opinion? Also, what questions should you ask your urologist on the initial visit if you're seeking help with fertility? That's a great question. Many urologists do not do a lot of infertility work in general, and so they're going to give you a lab panel and like a general recommendation. So I do think it's important to find a infertility trained person, if you can. Obviously, there's not that many of us because there's only about 15 of us that get trained every year or so. Most effective ways to boost concentration would basically still be those lifestyle things. That being said, I am a fan of using medications like clomiphene. It's sort of an empiric thing, but if you can raise somebody's FSH and LH production, even if you're not doing, like, I'm not going to say, oh, you have low motility, let's do clomiphene, or you have low morphology, let's do clomiphene. My philosophy is that if I can just get you more sperm, and maybe those other things get better too, but if I just get you more of them, your probabilistic estimate of successful pregnancy naturally does go up, right? And ultimately, there are 4 ways to get pregnant. The good old-fashioned way, intrauterine insemination, for which you still need, pretty good sperm, and then IVF, either with ejaculated sperm, which is challenging on, the female partners, but pretty easy for the guys to do, and then IVF, but with sperm extracted. And most of us would argue that our best power is to bump people up 1 level, but it's pretty hard to bump people up like 2 or 3 levels, right? It's hard to take a guy who at baseline needs IVF, ICSI, sperm extraction, microtesty, and get him to have a natural pregnancy. It's not impossible, it's just pretty hard. But can you get an IUI guy to natural? Yeah, maybe. Can you get an IVF guy to IUI? Maybe. And so I think that setting those kinds of expectations about what our powers are able to do is important, because some people ultimately, especially depending on the ages and all that kind of stuff, they may just truly need IVF as their best solution, because at the end of the day, sperm parameters on a semen analysis are a nice window, but that's not, like, nobody comes in and their real goal is to improve their semen parameters, right? That's not the goal. The goal is to have a baby, and that takes a lot more than just some good sperm, and it takes a lot of downstream things, and so you just want to keep that in mind. See the question here, any thoughts on vitamins such as NutriBloom, or what would you recommend to improve morphology and motility? I do think that vitamins have some benefit. The papers, some will say yes, some will say no, but none of them ever say it hurts. And I think that when you're looking at fertility, it's not like a broken leg where it's like, is it broken or not? It's not an on-off thing, a binary scale. It's 20 little levers or little volume knobs, and they're just trying to turn each volume knob a little bit so that hopefully it sounds better at the end. And so I think fertility vitamins is one of them. Probably the most well-studied one would be CoQ10, but I usually recommend that men take fish oil. Hera, the company that's hosting this, they make a good supplement. Some things have not a lot of data for, like there was a good study on zinc specifically that shows it doesn't do very much, but some things definitely do, and I think fortunately, unless you overdo it, because you can overdo vitamins, rarely will you overdo these kinds of things, so it is still beneficial to kind of try it. I think you're just trying everything you can, right? And that means the patients have to do their part too. No amount of fertility vitamins and Clomid is going to help if the guy is not at least somewhat motivated to lose weight, and he's like drinking 10 drinks a day and smoking like a pack a day, right? Like, we got bigger fish to fry. Vitamins aren't going to defeat that. But I usually tell the patients, like, if you are motivated enough to try and have a child, you are already basically telling yourself that you're about to sacrifice a lot of your own personal desires to help cultivate another life. And this is like your best opportunity to try and get your life in order as best as you can. 1, to be able to have a child, and 2, so that you can give that child the best environment to grow up in, because you will be around for longer, you'll be healthier, you'll be more active. If there was ever a motivation to try and do those lifestyle things, this is the time to do it, and it all probably helps, right? All right, this is a long question. Sperm agglutination grade. So sometimes you'll see on the semen analysis that the sperm will be agglutinized. I have seen people give guaifenesin for this. That's like not cough suppressant. It's like the mucus dissolving stuff. Sometimes, actually, to get to this next question is, yes, there is probably such a thing as your sperm being too stale, right? And look, I am definitely not a believer in like semen retention or whatever people talk about, but there is probably some validity to the opposite of that, which is you should probably flush the pipes every so often. Now, is that a physician prescription to, ejaculate? Not exactly, although some guys like to swing it that way. But I think that especially if you have high DNA fragmentation or oxidative stress, uh, ejaculating more frequently or using quote unquote fresher sperm may be better. Actually, to answer that question on the DFI thing, if you have a really high DNA fragmentation, there is some reasonable evidence that testicular sperm, meaning sperm that is earlier in the process and hasn't like sat around in the epididymis for a long time, may be better in terms to IVF success rates. And so, that takes a lot of counseling because it's a lot more work to have to do a testicular sperm extraction for just isolated DNA fragmentation index being elevated. But there may be some data, especially in a couple that maybe has already gone through IVF once and had an early pregnancy loss or a non-fertilization. Maybe you should get the sperm directly from the testicle. And the corollary to that philosophy for anybody that's not doing IVF is that maybe fresher sperm is not a bad idea. So, ejaculating every 36 hours, I think reasonable. Maybe don't want to hold on to like 2-week-old sperm, certainly. Somewhere between like probably 2 to 5 days is sort of that window that's totally made up. But, certainly that's how we counsel people when it comes to doing semen analysis, because I think that you do want at least a little bit of a fresher supply. There's a series of questions on using Clomid or HCG, and I am generally pretty aggressive about using these things. So there's 3 medications. 4, Clomid, which tells your brain to tell your testicles to produce more FSH and LH. Anastrozole, which blocks estrogen conversion and increases intratesticular testosterone. HCG, which is LH, but injected, and recombinant FSH, which is FSH, but it's really expensive and kind of hard to get. And I think that in the absence of other things, it is usually, I think, from a probability standpoint, perhaps beneficial. And most of the data on, empiric treatment with Clomid or anastrozole or things like that do show some improvements. Again, not necessarily in live birth rates, but in semen parameters. And that's the challenge with fertility, because this is the only field in medicine that you have to treat 2 people at the same time. And therefore, that's part of the reason why all the data is so messy, because I could take 100 guys and have a nice data set with their semen analyses, but if their partners are anywhere from age 20 to age 50, the eventual outcomes of live birth rate is going to be heavily dependent on that and whatever medical factors are going on there. So that's part of the issue. But I see my only power, is to try and get the guy the most and best sperm as we can. And then what he does with that sperm, if it does it on its own, if he does IVF or whatnot, that's where I use my REI colleagues, and we kind of work together in concert for these kinds of things. But that's what we can do, right? So, all right, I have probably 4 more questions, and then unfortunately I got to get back to clinic, but I can hopefully answer some of these more later. Positive and negative factors affecting motility. So again, a lot of questions are always the same thing. How do I change this one element? And we don't really have many great things. Coffee is not bad. I mean, there's 1 or 2 studies that show coffee increases motility. I don't know if that's more like just kind of pretending like the coffee's making them swim faster, but it certainly doesn't hurt. That being said, on the other end of the spectrum, alcohol, probably not good. Smoking, definitely not good. Oxidative stress and all that kind of stuff. Root causes of low testosterone. Low testosterone, very highly associated with infertility. Probably one of the most common causes of preventable infertility is men taking exogenous testosterone. A lot of people take tea, does a lot of good for a lot of people. A lot of people don't realize that it kills your sperm. Some, injections, for example, do more than other things like oral testosterone, but it definitely is not a good sperm-friendly thing. And so it's amazing how many guys I'll see in my clinic. They're like, yeah, I'm trying to have a kid. It's been 3 or 4 years. I can't do it, and I got no sperm. And then I'm like, so what are you taking? And they're like, just a little testosterone. I'm like, okay, that's the answer. Yes. All right. What causes high FSH? In general, that is a sign that something about the Sertoli cell function, i.e. the spermatogenesis section of the testicle, is not functioning well. They may have preserved LH, right? So the 2 cells, there's 3 cells in the testicle. Leydig cells, Sertoli cells, and the spermatogonia. The Leydig cells, LH, makes testosterone. Sertoli cells help stimulate, and then the sperm get made. So it's an interesting thing. If you ever hear something called Sertoli cell only, that sounds like you don't have Leydig cells. That's not what it means. It means you have Leydig cells, you have Sertoli cells. What you don't have are the actual sperm progenitor cells. In general, between the two types of cells, Leydig cells are much more robust. So a lot of people can have low-ish or actually decently normal levels of testosterone, but have really bad sperm, production. It's pretty rare to have the opposite, where you have like great sperm but low testosterone. But a lot of factors. Mostly nowadays, it's less genetic and more like just acquired lifestyle stuff. Poor sleep. That's probably the number one thing. That kind of thing. So can hormone medications like Clomid help before doing a microtesty? All of these things, I think it depends on who you ask. But if I'm going to do a microtesty on somebody, I'm going to put him on Clomid. I'm going to put him on an anastrozole. I'm going to spam his body with as much extra hormonal help that I can get, because if I am doing a microtesty, I'm already telling myself that this guy either has zero or like a few sperm, and if I can make a few sperm into a few more sperm, then my likelihood of finding something is better. And committing a guy to a microtesty, you got to put him under anesthesia, you got to cut open the testicles. By removing some of the testicular tissue, he doesn't have as much testicular tissue next time, so the first microtesty is sort of your best chance. You might as well give him the best chance of the best chance, which is to give him all the medications up front and hope for the best, right? Whether or not it does anything, you don't know, but at least we tried. Honestly, that's kind of a good theme of fertility in general, and something that I'll probably have to end on because I got to get back to clinic, which is at least you try. And there's a lot of things that you can try. And unfortunately for some men, no matter how much you try genetically, it's just not in the cards to have genetic paternity. That being said, there are a lot of ways to achieve paternity that do not involve genetic paternity: adoption, donor sperm, all things like this. Wonderful ways of having a family regardless. Fertility science has evolved in one sense, which is that it used to be really awkward to have to come into the clinic and do a semen analysis, in the office and in a dark room somewhere with some old magazines. And nowadays, with companies like Hera, for home fertility tests, we very much advocate that every guy, like at age 18, should just do a semen analysis test. It's so easy. You're already doing that stuff, i.e. masturbating anyway. Right? And you can just do it at home and you get some insight. And what really is tragic is when you have a couple that comes in and they've been infertile for like 2 years, and the woman has been through this $1 million workup and the guy's never even had a semen analysis. That is like the most tragic thing, because he could have done it at home 2 years ago, and we could have started working on things a long time ago, and it's cheap and it's easy and you can do it privately. And nowadays, I think with the advent of AI, it'll be really interesting to see going forward what kind of new insights we can bring in terms of giving people probability estimates. But at the end of the day, that's what it is. It's probability, and it's increasing your chances. It's trying to load more dice to go to the casino and play this game. And sometimes it takes a month, sometimes it takes 3 years, sometimes it takes you rigging the system by doing IVF. But we do what we can. Thanks, everyone. I know we had a little late start here, but appreciate your attention. I'll try to get through some more of these questions maybe after clinic sometime and post them on the Reddit. Our clinic, in case you happen to be in Dallas, Fort Worth, or North Texas, we're called Urology Partners of North Texas. There's 36 of us, but 2 of us basically do all the male infertility, and we're in Arlington, right between Dallas and Fort Worth. Thanks again, and good luck, guys. Take care.